Bruce Pyenson, Principal and Consultant Actuary with Milliman, stopped by the EBA offices to talk about the latest Milliman Medical Index. First, we asked Bruce to explain a little bit about the index.
The Milliman Medical Index provides objective information about how medical costs are allocated and how they're increasing from year to year. This is our 5th year, and it shows unfortunately a steady increase in medical costs, although medical costs aren't increasing as much as in the past. They're still increasing way more than the rate of inflation, or the general rate of inflation, or the increases in productivity in the United States.
Typical healthcare costs for a family of 4 have gone up 7.4% in the last year. We asked Bruce to share his opinions on why.
There's a couple of components of medical inflation for medical costs. One of them is the number of services being performed, and the other is the unit cost. So that what we've observed is utilization has become relatively flat. Unit costs continue to increase. For example, hospital utilization is no longer increasing the way it has in the past, but the unit price, the price per day or the price per admission, is still going up. Now, the decrease in utilization, or the stability in utilization, is promising because the studies that we have done and others have done have shown that there's a large amount of hospital utilization that's avoidable or not necessary. That's recently come to attention in various places like MedPAC, or the Senate Finance Committee, or Peter Orzog's work on readmissions and avoidable admissions. Medicare started the RAC audits, the Recovery Audit Consultant program, to look at short stays. So all that is tending to place attention on the potential to reduce hospital admissions and hospital costs. So I think we're beginning to see some of the effect of that.
The index showed that the percentage of growth in healthcare spending has slowed. We asked Bruce if this was a bright spot in the report.
It was that is a bright spot. It's looking hard to find one. The medical inflation rate and benefits costs is still way higher than productivity, and of course way higher than the growth of the economy. The United States is spending over 16% of its gross domestic product on health care, which is far more than any other country in the world. That is, we had done the paper on imagining 16 to 12, that even if we cut healthcare spending by 25% as a portion of, in real dollar terms and as a portion of our GDP, it would still be way higher than any other country in the world. So bringing down the rate of growth, as some prominent people in the industry apparently promised and then apparently did not promise, is really a justification for the status quo, in my opinion. That's not a cause for expecting big change.
Next, we asked Bruce to share some of the highlights from the report about ways to manage costs.
Well, employers, of course, are at the receiving end of all of this. They're the buyer. What I recommend for employers is to really bring accountability to their vendors, whether it's third-party administrator or an insurance company, or the other vendors that are selling products to their programs. You see a lot of vendors claiming to bring results, but really not being held accountable for them. So in our consulting to employers, we see a lot of potential to basically eliminate some of the vendors, some of the programs that don't bring value, and to bring accountability to the others. I think those, for example, examining the inefficiency of hospital admissions, and the employer shouldn't be paying for that. It should be the health plan that creates the incentive to avoid things like ambulatory care-sensitive admissions. Those are admissions where better primary care would have avoided the admission in the first place. In a number of places we see excessive short-stay inpatient stays. And of course the readmission rates are a huge issue, where a high portion Medicare, and also commercial discharges end up with a readmission within 30 days or 60 days, and those are all examples of poor quality and poor outcomes. And
we asked about what types of changes in benefit plans could be expected for the future.
Today is a wait and see on healthcare reform, but what seems to be emerging with healthcare reform is that even if there is a federal or government plan, that's going to focus on the individual market, the uninsured, and small groups. So large employers are going to probably conclude that they've got to act and act now because they're not going to get help from the government unless they're General Motors. But more broadly, I see two broad categories of change. One is towards better value, and the other is towards lower cost, and sometimes those get mixed together. Certainly, there's ways of doing HSAs that bring better value to members and better promote more intelligent spending by members. But I also see a renewed interest in restricted benefit networks, the classical HMO model, because I think the realization is that restricted networks and HMOs can actually bring very good quality at a lower cost. So there's going to be, I think, a move in both kind of directions. Basic cutbacks in benefits on the one hand, or focusing the benefits on things that bring better value. What we're probably going to see as well is a lower tolerance on the part of employers for some of the fringe benefits that were supposed to bring value but appear not to have worked. Things like disease management or wellness or things of that sort, or employee assistance programs and so forth, and to really focus on getting core value for medical benefits, meaning benefits brought by medical professionals.
Next, Bruce shared his thoughts on insurance connectors.
And I think there's a lot of merit to that. One of the advantages of connectors for insurance buyers is that it's a way to change the costs of distribution for insurance companies. You know, a lot of insurance company administrative cost is the distribution, meaning sales, marketing, and it's interesting. You know, I've got some gray hair, and the medical loss ratio and the administrative loads for insurance have pretty much stayed the same for 25 years, and it's ironic that in a time when administrative costs for just about everything seem to be going down, that hasn't happened in the insurance industry. I think the insurance industry would welcome, cautiously, but would welcome things that made the system more efficient in that way. So I think there's going to be a lot of support for some better, more efficient way of connecting buyers with sellers in the insurance market.
Next, we asked Bruce if he thinks next year's Milliman Medical Index will have a public plan option included in it.
I think the people who are involved in putting together the Milliman Medical Index, I'm sure, are considering that. I'm not the originator of this report, but I suspect that the federal or the government plan in some form won't be a reality with a lot of members in 2010, but I think we'll have some good ideas on what it's going to look like. So I think at that point we'll be able to put some price tags on it and compare it to what we've been spending and what and have been spending in previous years.